you very much. Thank you for the invitation. I'm glad to be here. Thank you for the introduction. I'm always, Mark Twain said, I'm always embarrassed by these introductions. There is so much more to be said. Anyway, now that we know about Alzheimer's disease, let me tell you what is going on, what is wrong. Because Ezio, in his excellent lectures, ended by giving us a list of what is left. But he didn't tell us what is right. And I think this is a question. So I will try to answer, to shake the boat a little bit, and to ask you, or to tell you what I think, why have we failed to cure Alzheimer's disease? So I have no disclosures, unfortunately. So what is Alzheimer's disease? We all know. This is the definition. There is no other definition. Anybody here in the lecture hall whom I would ask to define Alzheimer's disease would define it in this way. But please note that this is a very unusual definition of the disease because it combines the clinical features and the pathology. I cannot think of any other disease in which the definition necessitates a combination of both the clinical manifestations and the pathology. It's a complex problem. So trying to solve this problem with magic bullets, we have failed because complex problems may have many simple solutions, but they are all wrong. And here you see the list: cholinergic loss, trophic factors, aluminum toxicity, calcium excitotoxicity, and this and that. And at the end, also amyloid toxicity. It also has failed in spite of all that you have heard so far. And the fact that we have failed in trying to solve this problem is, I think, we have used incorrect assumptions. Think of it. So many clever people with enormous resources, with $20–30 billion, have worked for 20–30 years and did not manage to solve the problem. This can only be because some of the assumptions that they used were wrong. And I wrote something like that many years ago, or several years ago, but I will elaborate on this now. The first incorrect assumption is that it is easy to diagnose Alzheimer's disease. So we all know we can all diagnose Alzheimer's disease based on the criteria. Is it so simple? We use the clinical criteria, and it turns out that no. That firstly, there are many people whom the pathologists will say they have amyloid load in their brain, but they were not demented. If I drop dead now, and they will perform an autopsy, and they will show that my brain is loaded with amyloid, I hope not many of you will say, we knew it. So on the one hand, there is this amyloid which is frequent in people with of old age who do not have any cognitive impairment. And then there are also the other side of the point. The people whom we say as clinicians, they fulfill the criteria, and the pathologists will say, no, you are wrong. 30% maybe in the best centers in the United States, these statistics come from. So it is not easy to diagnose Alzheimer's disease. The second incorrect assumption is that pathology is a gold standard. And I think we've heard it in the last lecture. Is pathology a gold standard? Should it be the gold standard? Well, it has many different limitations. The most important thing, and I can don't have the time to go through the list. But the most important one is that pathologists cannot diagnose dementia. So if I drop dead now and my brain is loaded with amyloid, the pathologist can just state that this is what they saw, but they cannot say whether this was sufficient to cause dementia. And what I say about amyloid is also true about tau pathology. The third incorrect assumption is that these characteristic histological changes define Alzheimer's disease, the neurofibrillary tangles and the plaques. When we're talking about this, are we losing the big picture? Because, of course, we see through the microscope the NFT and the amyloid plaques. So looking through the microscope, we see the details very clearly. But this prevents us from seeing the big picture. The big picture, as we've heard already, is the loss of tissue, not a deposition. And we do not know that the amyloid or the NFT cause neurodegeneration. And I think Virginia has mentioned this, that in her studies, there was no neurodegeneration in spite of much pathology in terms of tau. What about cell loss? What about synaptic degeneration? What about white matter lesions? These have been studied, shown many, many times. I will only quote this paper from Leah Greenberg and her colleague, who showed that there is no correlation between tau or amyloid pathology and cognitive function, but rather cell loss is the important thing. And we do not know what causes the cell loss. And the assumption that it is either amyloid or tau is an assumption, and it is not supported by data. So the incorrect assumption number 4 is that amyloid is responsible for the dementia. And of course, there is a correlation, sort of, between the amount of amyloid, the position of amyloid and cognitive impairment. But correlation is not causation. For those of you who fail to believe me, there is this important paper in New England Journal of Medicine. This study tried to compare chocolate consumption in different countries with the number of Nobel Prizes given in that country. And surprisingly, there is a straight line. Straight line. Of course, there are outliers. You see that Germany is below the line. We all know why Germany did not have many Nobel Prizes in the 20th century. What I don't understand is why Sweden is above the line. This is a mystery for me. Why should they get more Nobel Prizes? That's a mystery. Anyway, this strong correlation between chocolate consumption and number of Nobel laureates in that country did not convince any government to start giving away chocolates in the hope that the country will earn more Nobel Prizes in the future. So correlation does not prove causation. The fact that cognitive impairment is related in some statistical test to something that you see in the brain does not mean that this is causal. But this is the basis of the amyloid-centric pathway in Alzheimer's disease, presumed Alzheimer's disease. And 10, 15, $20 billion have been invested in trying to find the fine details of this pathway. But this has led us so far nowhere. And the amyloid cascade hypothesis is really defunct. So the fact that AD is associated with amyloid deposit is so by definition. But to say that it is caused by amyloid deposition, or by tau for that matter, is a theory. This is an assumption that needs to be proven or disproven. The main problem that I see is this incorrect assumption that there is only one Alzheimer's disease. That's not true. What Augusta D. demonstrated was a unique case, and Alois Alzheimer identified her as a very unusual person, disorder, unlike any that he has seen, and he saw many older people with similar pathology, but said this is different. And of course, we know that this is different. We know that Augusta D had a presenilin 1 mutation. So to have presenilin 1 mutation or presenilin 2 mutation, definitely APP mutation or trisomy 21, which also increases the production of amyloid, these are genetic variants, but these are genetic variants of a genetic disorder. And it is incorrect to think that the sporadic form of Alzheimer's disease, what we see now as an epidemic, is the same as this unique genetic disorder. To say that the sporadic AD follows the same pathogenetic roadmap as familial presenile AD, again, this is an assumption which led to, again, to many, many studies, but I think it's an incorrect assumption. Enhanced AB synthesis would occurs, of course, in all these genetic mutations, but not in the senile form of Alzheimer's disease, not in old age. There is no enhanced production of amyloid, but rather a problem of removal. And this problem of the removal is why we see that there is a loss of amyloid in the CSF in these cases. The seventh incorrect assumption is that transgenic animals mimic the important steps in the human neurodegenerative process. So these transgenic animals used the APP or the PS1, and usually both of them, to try to enhance the production of amyloid in the brains of these animals. And of course, you force these animals to make A beta, so they make A beta and deposit A beta. But these animals do not have tau deposits. Of course, they have a lot of tau in their brain, but nothing more in patients who have these genetic mutations imposed on them than normal tau, normal animals. They do not have normal neuronal loss. There is no inflammation, these important things that have been mentioned by Ezio before. And of course, none of them becomes demented. They all behave practically normally. Of course, if you do a water maze study, you can see some deficit. But none of them needs to be cared for. None of them needs to be fed. None of them misbehaves. They all look like normal if you look at them from the outside. So the transgenic animals are not a good model of the senile form of Alzheimer's disease. But following these incorrect assumptions, they thought that if we get rid of the amyloid, we shall heal the brain. And potential therapy targets which have failed have all been mentioned by Ezio before. And I think the targeting therapies against amyloid or tau aims at downstream markers of pathology, downstream markers, which are not necessarily pathogenetically important. So removing them is just going to the cemetery and removing the tombstones and hoping that somebody will come back to life. But doesn't happen. Of course, you can study the tombstones, you can learn a lot about who is laid there. You can see, you can ask yourself at what age people died. You can look at the stones themselves and ask where they were, where is the quarry from which they were taken, what enzymes were used to cut these stones in order to make them tombstones, and so on and so on. But this, studying the amyloid cascade, will not help you to revive anybody who's already dead. Not a human person, neither a neuron. So how is beta amyloid related to sporadic Alzheimer's disease? I'm talking about sporadic Alzheimer's disease, which is different from the early onset familial genetic disease. Is it just an epiphenomenon? or a manifestation of old age, because we do know that people who are non-demented, if you look at them and do the PET studies that we've just heard of from Ezio, we'll see that as the age increases, more and more and more people have amyloid deposition in the brain. These are non-demented people. They are not more likely to become demented in the future. And there are studies to show that. So as I said, it's incorrect to assume that AD is a single disease entity. What is Alzheimer's disease? When we talk about Alzheimer's disease, what do we mean by a disease? For me, a disease, of course, diseases do not exist except in our brains. These are abstract concepts, which and we call something a disease when it is encompassing the underlying process and with a common etiology. And then the pathogenesis and evolution pathology come next. So in Alzheimer's disease, both the clinical manifestation and the pathology are due to phenotypic convergence. Sporadic AD is a multifactorial disease. It's a complex progressive neurodegenerative disorder caused by a heterogeneous combination of environmental and genetic factors. And because of its complexity and etiological heterogeneity, it is not really a disease in the classical sense of the word. And all those patients who came into the studies with fulfilling the clinical criteria and the imaging criteria of having amyloid and tau, all of them have a lot of additional pathology. In old age, we all accumulate pathologies in our bodies and in the brain. We all have not only amyloid and tau, but also many other pathologies, vascular for sure, as well as others, which are small and by themselves would not be sufficient to cause a problem. But on top of something else, they can be the decisive factor. This can be like this, as we say in the Middle East, the straw that breaks the camel's back. So Alzheimer's disease, or the amyloid cascade hypothesis of Hardy and Higgins that we've heard about, is a hypothesis, was put on a hypothesis. And Karl Popper said the important thing in science is falsification. A theory must be subject to falsification. If it cannot be falsified, if you cannot think how it can be falsified, then it's not a scientific theory at all. Then it's a religion, maybe. And the great tragedy of science, said Thomas Huxley, is a slaying of a beautiful hypothesis by ugly facts. So I don't deny that the amyloid hypothesis was a beautiful hypothesis. But the facts, now for 25 years since this paper has been published, could not confirm it, could not show any evidence of that, and in fact all the studies that have been done, all the billions of dollars that have been invested trying to go along this line have been wasted, and I'm afraid that if the industry will follow Ezio's suggestion and will go down with tau, then we are going to lose another 20 years or 30 years and so much money without any success. What is it? Actually, we know that as we age, everybody who ages, the aging process includes age-related neurodegeneration. And also we know that there is age-related amyloid deposition. And AD is just the overlap between the two. Just the overlap between the two. It's not a disease. This occurs irrespective and does not lead to cognitive decline. This occurs irrespective of amyloid and does lead to cognitive decline. And this is multifactorial. And just the artificial overlap that we have between this and that was misleading us for so many years. the potential causes of senile dementia, and we should call it senile dementia, not Alzheimer's disease. Alzheimer's disease is a misnomer. It was taken from the original genetic early onset disease, which is a different disease, and used for old people. And the epidemic now, the people who have Alzheimer's disease, what we call Alzheimer's disease, but actually are demented, the cognitive impairment of old age, is contributed to by many, many factors. And you all know that this happened. We all know it as clinicians. We know that there is genetic predisposition. Nobody has mentioned ApoE4. It's a very important contributor. Microvascular disease, they exist in everybody. Advanced protein glycation, hyperglycemia, recurrent hypoglycemia, hypercortisolemia, depression, inflammation, and this and that. All these factors contribute to the phenotype that we call mistakenly Alzheimer's disease, but we should call, as we did before, senile dementia, which is not a disease. It is a condition. So the take-home message is that senile dementia is a complex progressive cognitive disorder characterized by brain atrophy and frequently deposits of plaques and tangles, caused by a heterogeneous combination of environmental and genetic factors. And because of this complexity and etiological heterogeneity, it is not a disease in the classical sense of the word. Amyloid and tau are downstream markers unlikely to be associated with disease pathogenesis and therefore unlikely to be used as drug targets. Take-home message: senile dementia cannot be cured, but it can be prevented or at least delayed if we think about all these factors like hypertension, hyperlipidemia, and this obesity that we all warn our older people against, because we believe that this contributes to cognitive impairment. So Alzheimer's disease cannot be cured, except for the early onset genetic Alzheimer's disease. This can be cured easily. This can be cured easily. It's a monogenic disease. Now we have the tool to silence the gene, the presenilin gene, the abnormal presenilin gene. The person will continue to live normally, and there will be no dementia in these people. It's very easy. Almost done next year, much before all these immunological studies will be completed. And with this I will end, inviting you again to see you and to hear in what I was wrong and what others were right next year in Madrid. Thank you very much for your attention.
Thank you, professors. There is a question.
Amos, you were much, much more controversial than I was. I was just very mildly controversial. Now I give you a challenge. You have to write it down. If in 2028 I will come here, very unlikely because of my age, and tell you that immunotherapy of A-beta and combined with immunotherapy of tau in preclinical subject is able to block or consistently reduce the disease, will you then say, Ezio, you were right, I was wrong, it is a disease?
Yes, I will eat my hat then, but as you see, it cannot happen because I have got no hat. No, I think that there are also other issues that we don't have time to discuss, but this amyloid and tau hypothesis that you put forward at the end cannot solve the problem at all, because it will be so costly. And we've heard from Professor Redak about the number of people worldwide that will be demented at that time. That will be impossible. Also, the studies will be so long that I think it will be very difficult to prove this, but I think in principle it will not be. But if it will, I'll eat my hat and I will say, here we are. Thank you.
Hi, John Hardy here. I thought I'd just arrived, so I thought I should give Amos a little bit of a hard time. I'm here, Amos, on this side.
Yeah, I see you.
So,
welcome, John.
Always nice to hear you, I think. Do you think that if we had, for example, a BACE inhibitor, something that inhibited BACE amyloid production in Down syndrome, and we gave that from, middle age, do you think that would help those people?
In Down syndrome?
In Down syndrome.
Down syndrome, perhaps, yes. I said this is a different disorder.
Yeah, sure. So wouldn't you say then, that's what I think too, and I absolutely agree, wouldn't you say then that a sensible way forward would be to see things which work in that sort of way in Down syndrome, and then see whether they contributed, and I agree there are other morbidities in late onset Alzheimer's disease, and see whether that approach would then work to some extent in late onset disease. Wouldn't that be a rational way forward?
No, I think not. I think not all that looks the same is the same. And the fact that there is amyloid there, it is by itself not a reason to do it. The pathogenesis of APP mutations, presenilin mutations, and Down syndrome, trisomy 21 are separate disease. And there, probably amyloid production is part of the picture. I don't know that it's the whole picture. You know that it's difficult in Down syndrome, which you've mentioned. There is not just the APP gene, which is doubled. There are many other genes in the neighborhood which are also may be contributing. No, I think I will not have the strong objection to study it, but I will not invest my money in any of this.
I'll help you buy a hat.
Okay. It should be nice.
Yes, please.
Thank you very much. What about treatment of MCI? What about MCI?
Sorry?
What about MCI, mild cognitive impairment, treated or not?
Yeah, I think this issue of when to start treatment is recurring. I think it's the amyloid target is confusing because it moves all the time. First we thought it's a plaques, then we thought it's a tangle, maybe the fibrils, maybe the monofibrils, maybe it's extracellular, maybe it's intracellular. After all this has failed, the drug company said, okay, maybe it's too late. Maybe it's too late. Maybe we should have started, as you say, at the MCI stage. When patients come to me, usually many of them are already in more advanced stage, are not MCI anymore. And what they want from me is they tell me, look, I know it's Alzheimer's disease, I know what's going on, I just want to remain the way I am. And I tell them, sorry, all the studies that try to attack amyloid and now tau have failed in this. I'm sorry. We can, and the question is, what is the process that drives the pathology of these people from the point that they come to me and they can still talk to me and understand what's going on to the stage in which they will die, which is complete loss of human nature. And we don't know what it is. But had we known, had we examined this, had we studied this, then the next question would be, when did this process start? Maybe this process that drives them to lose everything started 20 years before. And if it's not amyloid and not tau that drives them to go on further downhill, then what is it and when did it start? And I think we lose a lot of time not working on this issue as well as on many others.
Okay.
There is a question here.
The last question, please. Okay.
Thanks. Yeah, it's not just because I'm UK, I'm siding with John, but I'm afraid agnostic about the question. But I think that we may have been a bit misled when John Morris told us all it was a failure of clearance, because it probably is a failure of clearance. But also, I think as we get older, we probably are overproducing, because amyloid's a physiological protein, and we produce it for a reason. And I suspect some of the reasons the lifestyle studies are starting to work is that actually controlling hypertension, amyloid has a range in the literature of actions, including hypertension, homeostasis in the brain, amyloid, carbohydrate metabolism, cholesterol metabolism. So I suspect a lot of these lifestyle things may actually lower amyloid anyway within the brain, and we saw some good stuff in Turin on that. And so overproduction may be an equal problem. So the comparisons between the genetic and the late onset, there may be some more than you are allowing at the moment. So I'm agnostic, but I would probably side a bit with John, but I won't buy you a hat.
Okay, so
this remark does not request a reply. Thank you very much for this comment.